Well, hello everyone. Thank you so much for coming along to our Tea with the Experts webinar, and it's wonderful to have you all here. All of your cameras and microphones are off, but there is a Q&A box at the bottom of your screen. So if you have any questions, please pop them in there and we can ask them at the end of the webinar. So let me introduce you to our hosts and experts for today. Our first expert is Professor Geoffrey Tofler, who has over 20 years' experience as a clinical consultant cardiologist. His expertise is in the prevention of heart disease and the management of heart failure. He is very widely regarded in Australia and internationally for his research work in the causes of heart attacks and has co-authored hundreds of peer-reviewed journals and book chapters. Our next expert is Dr. Karan Rao, a cardiologist with an interest in interventional and structural heart disease. His current research is an innovative project looking at a method to reliably predict patients at risk of heart block following their TAVI, which we'll learn more about this afternoon. I want to hand you over to our wonderful ambassador, Chris Russell, who generously gives up his time to host these sessions and has a knack of asking all the right questions to help make the research more understandable. He's back on his travels and he's joining us today from Renmark. So I will hand over to you, Chris.
Yeah, hi Felicity. Yes, greetings from not so sunny South Australia, but it's wonderful to be able to bring another one of these sessions. This one is a little bit different to the sessions we've done before because I was thinking about the theme for this session, and this is really about the old saying, prevention is better than cure. Or if you like to put it another way, time spent in reconnaissance is seldom wasted, which is the old Duke of Wellington's first principle of war and, you know, what I learned in the army. And this is what this session is all about. It's different to fixing the problem after it occurs, which, of course, you always have to do. But the most important thing is to make sure that we try and prevent it occurring in the first place if we can. So the first guest that we're going to speak today is Dr. Karan Rao. Now, Karan is doing a current project tied up with Shaw, curing a problem, which is something we have, but what do you do after that problem? And the problem that, Karan, you've been focusing on is that of fixing aortic stenosis. Now, for a start, you better tell us what that is.
Yeah, sure. Good afternoon, everyone, and thanks for having me. So, aortic stenosis refers to narrowing of the aortic valve, and the aortic stenosis is the most common valvular disease that exists, and it affects almost 2% of the population over the age of 55. So, classically, it's classically a condition that becomes more prevalent as we age, and as some of you may already know, the heart has four main valves, and the aortic valve is the last valve, which basically allows blood to exit the heart and go to the rest of the body. When it's narrowed, then the blood can't do its function efficiently or effectively, and enough oxygen and blood supply does not reach the major organs of the body. So aortic stenosis is, when severe, is a severe condition, which can have a mortality or a death rate near 50% at 5 years if it's left untreated. It's basically the focus of my interest and my research, and that's it in a nutshell. So it refers to usually degeneration and calcification of the valve apparatus itself, which causes that stenosis or narrowing and a failure of blood to efficiently leave.
And tell me, Karan, how do you know if you've got it? How can you diagnose if that's a problem?
There's a few ways, Chris. So I think largely aortic stenosis remains asymptomatic, so it doesn't cause symptoms until it gets to a more moderate or severe stage. And the most common way it's detected is through patients reporting classical symptoms. So in the textbooks and in the literature, there's a triad of classical symptoms. These include shortness of breath or dyspnea, chest pain, quite similar to angina that we link to heart attacks or ischemic heart disease, and finally syncope. Now, all three of these symptoms are related to that inefficiency of the blood to exit the heart. Now, outside of that, as cardiologists and doctors and health professionals, there's methods of detecting aortic stenosis. So these are referred to as the signs of the disease. And most classically, we rely on the stethoscope. Aortic stenosis causes a funny sound, essentially, when the stethoscope is put on the heart, and it's called a murmur. And this can often be the first clinical detection where aortic stenosis can be picked up before it actually manifests as symptoms.
So, I mean, all the doctors I've seen all wear their stethoscopes around their neck like a badge of honor, really. It's like a rank badge. So they've all got one. Why isn't this the most diagnosed disease, in history, if that's the most common instrument?
I guess I'm not sure how exactly to answer that, but effectively, I think aortic stenosis its prevalence is, as I said, about 2%, and that's primarily over the age of 55. And I think there is a growing trend of an awareness of the condition. Classically, patients have already had a general practitioner or an emergency physician or another doctor listen to their heart, and that's before they make it to the cardiologist. So there is this growing trend of increasing the awareness of the condition to all medical professionals, so that everyone at first contact is looking for the condition, particularly when those cardinal symptoms are at play. But no, you're right. It can be picked up quite quickly. So the hope is that any professional, any medical professional, whether it be your GP, your local doctor, even if you go to ED for a separate reason, can use their stethoscope to pick up the early symptoms, or early signs, I should say.
And is it something that's for older people, or can be seen in young people as well?
We think that there's a bimodal or a kind of a split. So historically, classically, degenerative or calcific degenerative aortic stenosis tends to be in the elderly population. So as I said, the prevalence tends to rise after the age of about 55 and 60. And that's because age-related wear and tear leads to these calcific deposits, which narrows and stenoses the valve. However, there is a younger group where we think roughly between 45 and 60 years of age. And the reason we think this group of patients get aortic stenosis is due to a congenital or a born abnormality, where instead of having 3 cusps or 3 parts to the valve, they might be born with 2. And as a result, the flow through the valve is abnormal through their child and adult life. And because of these differences in stress and flow, they degenerate a lot earlier. So that's the kind of bimodal distribution. But classically, it's a disease of the elderly. But yes, we do see a fair incidence in that 45 to 60 cohort. Classically, in that cohort, it's because of that congenital bicuspid aortic valve.
Yeah, so this is not like a tap washer then. This is more like some flaps of skin which close up and open up. Is that right?
That's right. Yeah, that's right. It is just tissue at the end of the day. And it's subject to the sheer stress of blood opening and closing and blood flowing through. So there is kind of endothelial damage done to this tissue over time, and then the body reacts to it with calcific deposits and age-related wear and tear, effectively rusting of the gates, so to speak.
So once the gate's rusted or the tap washer's blown, do you just replace it? And what do you replace it with?
So historically, the answer is yes. You do need to replace it. There's no repair available for this type of condition. And historically, up until about the early 2000s to about 2010 or so, it was done purely as a surgical aortic valve replacement. When I say surgical, I mean open heart surgery requiring the patient to be on a bypass machine, cutting the heart open, and the cardiothoracic surgeon replacing the valve. However, there's been a kind of change in that paradigm with this new procedure called the TAVI, which stands for transcatheter aortic valve implantation. And that's the kind of the focus of my research and my interest. And TAVI has been around for about 20 years, but really used or utilized quite significantly probably over the last 10. And the difference between TAVI and the surgical valve replacement is that TAVI can be done as a keyhole. It can be done either through, most commonly, the groin or another access point to a major artery, which all feeds into the heart. And instead of opening up the heart and putting the patient on bypass, we can actually replace the valve in a transcatheter method from being well away from it. And what this means is that the recovery times are shorter, patients are up and walking the next day, usually later that same day. And it also means that we're able to provide this treatment to a lot more patients, because you can imagine an 85-year-old lady with critical aortic stenosis, she is not going to be fit for a full-blown bypass surgery. However, she might tolerate a TAVI. So this has been almost seen as a miracle treatment in the world of aortic stenosis, because it's allowed us to treat and alleviate this problem in a wide cohort of patients which previously had no access to treatment.
So when you say transcatheter, you mean like a stent where you put it up through a vein and then open it up, in the right spot? And if so, how do you get all that big valve all crushed down small enough to go up a vein and then open out again?
Well, whilst it's different to a stent, obviously, in a lot of different ways, fundamentally, it's actually very similar, and it's a good way to understand. So transcatheter means it's performed over wires. So all the equipment is railroaded over wires, which basically deliver the equipment into the necessary spots. And what happens is over this wire, this valve, which has been crimped or squashed down into a very, very small profile, is passed up through the groin all the way around the aorta into the aortic valve. And then the old valve is squished in its place by deploying this new one. So that's one fundamental difference, is that the old valve is not cut out like it would be in surgical valve replacement. It's actually left there. And this new valve squashes it and basically pins it to the side. And then the new valve acts as the new gate, basically. So it's done all.
So it's a bit like putting an O-ring in without taking the old O-ring out.
I guess so. Yeah, pretty much. Yeah.
So, okay, so in this squishing process where you squish it up tight and then you open it out and sort of make it kind of push into the sides of the aorta, does that do any damage, or, what happens when you do that, or is that okay?
That's a really good question. So it, in most part, does not. So there are some smaller complications, because what happens is, in the wide majority of cases, we don't see any issues. But in the minority of cases, some things can occur as a result of this. So one potential complication is when you pin the leaflets, what happens is the space near the leaflets, which normally had free-flowing blood, suddenly gets a little bit more stagnant. So in a minority of patients, you may get what's called leaflet thrombosis, which is a fancy way of essentially saying clotting of blood, which has become like a swamp or like a pool in areas where it was previously free-flowing. However, the main kind of complication of pinning the leaflets actually refers directly to my research, and that is the conduction system. So when you when you pin the leaflets to the side and you put this new valve in, you're creating room and you're pushing things to the side, and the normal conduction system of the heart, the normal pathways which allow the heart to beat, actually run adjacent to the aortic valve, which means when you put in this TAVI, there is about a 10% risk of pinning the leaflets to the side, creating room, and actually squashing these adjacent nerves. And this may leave the patient in 10% of cases dependent on a pacemaker. So that is an important risk of TAVI. And whilst TAVI is, much less risky in every other facet of, with regards to complications when compared to surgical valve replacement, when it comes to the pacemaker risk, it's got a marginally higher risk. And this is the fundamental reason, because we don't cut out the old valve. We actually have to create room and we squash it.
Okay, so there's a chance then that this nerve, which I assume is involved with making a heartbeat, gets squashed, and therefore you've got to have an electronic means of backing that up, if you like, which is a pacemaker. So why don't you just drop a pacemaker in all the hearts, just to make sure you've got something on standby in case that happened?
Yeah, in an ideal world, if a pacemaker had absolutely no complications, and if a pacemaker was a completely harmless procedure that lasted forever and no one would notice it, then yes, you would put a pacemaker in every patient that's going to get an aortic valve replacement, because 1 in 10 are going to probably need one anyway. But we don't do it prophylactically, or we don't do it without evidence of a requirement. And the reason is pacemakers aren't completely benign. So whilst they've become routine and common, what we know is that the pacemaker procedure itself carries a complication rate. You can cause a pneumothorax, you can cause infection, bleeding. It requires putting leads and wires into the heart. And then, of course, long term, what we now know with data is that over 5 years, over 10 years, patients with pacemakers have increased rehospitalization, and they may also have increased all-cause mortality. So basically, they do slightly worse than the patients that don't need a pacemaker. So there's a lot of different reasons for that, but one of the fundamental reasons is when you put in a pacemaker and when the patient uses that pacemaker quite a bit to beat their heart, there's dyssynchrony, and it's not a physiological or normal way for the heart to beat. So to cut a long story short, we do use it in the instances where we need it, but it's not done prophylactically or routinely prior to having evidence of a problem.
So does this, whether you're going to have a problem, does that show up straight away, or does that take a while for you to work out that you actually have crushed this nerve?
So in most instances, it shows up straight away within the first 24 hours. In fact, the kind of hottest time period is on the table. So as soon as the valve goes in the vast majority of cases, you know on the table whether there's going to be a problem. Then as time passes, we think the risk starts to fall. But what we're learning, and what, again, our research is trying to prove, is that this risk actually doesn't completely go away until about a year after the surgery or after the procedure. There's various reasons for that. The valve continues to expand, and it can kind of knock off the nerve all the way up until a year. But this is kind of shifting the paradigm a little bit. Most TAVI operators around the world, when they refer to pacemaker risk, refer to the first 24 or 48 hours. Some people refer to up to a month, but we're finding that maybe 4, maybe 5% of patients wind up needing a pacemaker because of a heart rhythm problem, 6 months down the track or 3 months down the track, all the way up until a year. So it can happen at any point, but definitely the hottest time period is early.
So let's say it doesn't show up early, and you've got home and you're sitting at home and it suddenly shows up. How critical is that for you to get in and get the pacemaker in, or can you sort of book in and do it next week?
Yeah, it's a hard question to answer. When you have the highest degree of heart block, which is complete heart block, where there is a disconnect between the top and bottom chambers. Now, as you can understand, there's a spectrum of rhythm disease or heart block. But if you have the worst form where there is a complete disconnect, then what our evidence suggests is that patient is at a high risk of fainting, of hurting themselves, of having a seriously adverse outcome, and even has a marginally higher risk of a cardiac arrest. So if we pick that up on monitoring or on an ECG or on anything, we tell the patient that they should go into hospital immediately because a pacemaker is required straight away. Now, we don't know whether they'll have those symptoms or those adverse outcomes then and there, or whether it'll happen in a week from then or in 3 days. But the advice currently based on literature is if we find that complete heart block, they should go into an emergency department or have a pacemaker worked out for them outside of an emergency department within the next few days. Sorry, Chris. I think we might have just lost you.
I think we might have temporarily lost Chris. Let's give him a second and hope he comes back.
I suspect that Chris would then ask you about what you could do to identify it, and getting a little bit towards the purpose of your project.
Yeah, definitely. So what the focus of our project is, currently there's various predictors for patients that might end up needing a pacemaker. But what we're trying to better understand is so really knuckling down into predicting which patients will need a pacemaker, and particularly which patients are likely to need a pacemaker once they leave hospital. So as you can probably imagine, that's a particularly high risk vulnerable group because the majority of these patients are elderly. They're over 70 years of age. They often live alone or with minimal support. And if they have a rhythm disturbance in the community, they may have symptoms or hurt themselves well before it's picked up. So the way we're studying it is we're putting in recorders, basically, rhythm recorders, which are implanted and monitor our TAVI patients' heart rhythms all the way up until 1 year. The purpose is, if we detect a rhythm issue, we contact our patients and we tell them to see their cardiologist or come into the emergency department or to come and see us or get a pacemaker. The purpose of it is so that we can do this a lot earlier than perhaps we would if they didn't have a recorder. And then we're going to be going and working backwards and finding out the patients that did have a problem. Could we have predicted it? Could we have predicted it on their baseline ECG, on some electrical analyses that we've done during the TAVI? So it does get a little bit more technical and specific there, but that's the nitty-gritty of our research, where we're monitoring them for a year and then working backwards for the patients that had problems to really see if we could have predicted it to help the future generations which may suffer from the same issue.
Can you hear me now? Sorry, I dropped out there for a minute.
Yes, welcome back,
Karen.
Yes, we can.
Sorry
that's all right. I was just talking about the research itself and the use of loop recorders to help monitor rhythm data for up to a year, to help us understand really which patients are at risk.
Yeah, so this is the point of your work, is to be able to say to someone, look, we think you're going to be at risk, therefore we think it's worth the potential problems with fitting a pacemaker in advance. And how do you think you're going to be able to predict that? What's your hypothesis you're testing, Karan?
Yeah, so the hypothesis we're testing is that it's a little bit technical in terms of electrophysiology parameters, but essentially what we're testing is that certain parameters, if they're abnormal in the patient before and after their TAVI, as well as certain predictors on their CT scan, like where their calcium is on the valve, the volume of calcium, the type of valve we used. Essentially what we're trying to test is that we want to come up with an algorithm to say that if a person has this and this problem, they are very high likelihood to end up needing a pacemaker over 12 months. And the kind of holy grail of this research is that if we can work that out, then perhaps patients that are extremely high risk, we can pick that up well in advance of them needing a pacemaker. And basically, we could potentially tell clinicians that, hey, this patient's high risk, you should monitor them for a little bit longer. Don't discharge them as per protocol in 24 or 48 hours. Potentially monitor them closely with some sort of a wearable monitor, perhaps for a week, for a month. And if we can work this out, I think it will lead us to the true win with the research, which is to get the low-risk patients home immediately and then pick out who the high-risk patients are and then watch them very closely.
So if you're talking about morbidity and survival and so on, the end result of this work, you mentioned 10% of the patients are likely to have this potentially unseen at the time of operation problem with a pacemaker. What percentage of those do you think you might save or give a better lifestyle through because of your research?
So I guess save would mean there's two main things. One is to prevent a pacemaker, which is always, prevention is better than cure, and it's always the best way to proceed. So if we know that a person is very high risk based on our research, then we might be able to adapt our techniques. We might be able to implant the valve in such a way which reduces their risk of pacemakers. Now that's a little bit technical, but you could potentially implant the valve higher, use a valve type which is shown to cause less pacemakers. So you could change how you do the procedure to help potentially prevent this complication. And then there's also the cure part of it, which means what we're hoping is that with our research, we'll be able to identify the higher risk patients, which means that we'll be able to pick up and diagnose the problem earlier, and then thus cure them and treat them with a pacemaker a lot earlier, rather than coming to hospital with a faint, injuring their head, having a bleed or something like that. So they're the two arms of prevention and cure, which I think the research has definitely got aims to fix both.
And how is heart Research Australia been helping you with this? So they funded the concept stage, the later stage. What have they been looking after for you?
Yeah, so Heart Research Australia has worked closely with the research group for a long time, and have been very, very helpful in setting this study up. They're supporting me personally through a PhD stipend, and have been extremely receptive for any publication costs covering, or any equipment cover. So very much involved, and I'm obviously extremely grateful for their support. And yeah, hopefully we'll report some exciting results back soon.
Well, I think you're a prime example of prevention being better than cure, Karan. And obviously, if we can not have people unnecessarily taking risks with pacemakers, but B, also predict when they're going to need one or have a problem that you can fix early on, that's got to be better than trying to make around with it afterwards. So thank you for your intellect and for your work on this. Like all of these studies, I'm sure that the total knowledge, it's amazing how we've improved, but you can just see how much further we're going to keep improving in terms of lifestyle and survival rates after what would have been basically a life concluding situation maybe 50 years ago. So it's extraordinary.
Exactly. Yeah. Thank you, Chris.
Well, and that brings us to our second guest today. Professor Geoff Tofler. And I must say, from your point of view, you're very much focused on trying to stop heart attacks happening in the first place before they start. Now, I know that we've spent a lot of money, as a country on education. You must keep running. You can't have more than a handful-sized piece of steak and all the things that we hate and don't want to do, and all this education. But people, in many cases, don't listen. But they do say, I remember another little saying that my father used to say, is nothing so focuses the mind as the sight of the guillotine. And I think a heart attack or some event is certainly a pretty focusing subject, as I found out myself when I was immortal when I was 52. Suddenly I fell into some cold water and found I wasn't as immortal as I thought I was. So tell us a little bit about what you've been. There's been some studies going on looking at people particularly doing a lot of sport in older age. How have they been progressing? Has that been as effective in stopping heart attacks, or what's been happening with those studies?
Sure. Look, thanks very much, Chris, and thanks for the invitation to speak. And it's on. This is Men's Health Week, so I am pleased to be able to talk about a study. It's obviously related to men, but it's related to football. Chris and I had a joke about it when I mentioned football. He said, "Do you mean the round ball soccer or real football?" Which I think you regard as rugby. Is that right, Chris? But
yes, you're talking about soccer, not football. Yes, but carry on. We understand what you mean.
Yeah. So I actually was a very keen soccer football player, and my son was, and I've now do it vicariously more by watching Premier League soccer, but also enjoy a kick around on a Sunday morning. And so I was very interested to do a survey to ask. These are what we call masters. I will say football because that comes more naturally to me, Chris. People are 35 years or older. So these are ones who are not doing it for money. They're often doing it from a social point of view, although also competitively. And I was inspired to do it because there was a World Masters football competition here in Sydney several years ago, and I did go to watch my brother-in-law play in it, and the guys were sort of really running very hard and very competitively, and some didn't look all that fit. And so I was a bit not anxious, but I wasn't 100% surprised when I saw that there was an ambulance at a nearby field, and someone had actually had a cardiac arrest playing football. And he was fortunately resuscitated with a defibrillator. And I then contacted him, and we had a good discussion. And so what it turned out was that he had some warning symptoms, which had happened when he was exerting himself, but it was not what we call typical ones. We classically regard typical symptoms as being, central chest tightness when you're exerting yourself, maybe radiating down the arm. His discomfort was actually more in his jaw and the back of his neck when he was exerting himself. And he didn't put it down to heart at all. But anyway, so fortunately he got to hospital. He had a stent put in, and is now actually back to playing football and doing well. But partly for that, I was inspired to do the survey with a medical student who led the way, together with a colleague, Tom Buckley, and some others. And so we interviewed 150 people, as I say, over 35. Most of them, I must say, were men, 92%, but we did have some women, and in subsequent studies, we do want to include more women, since football is becoming more popular among women, as we know, with the Matildas doing so well. So what we found was that in this group of average age 49, most of them actually were university graduates, so 75%. So it's perhaps, if anything, a particularly educated group. But what we found was that a lot of them had risk factors. So like a third of them had high cholesterol, 1 in 5 had high blood pressure. And what we asked them, it turned out that about 1 in 5 of them, so 20%, had had a symptom in the previous year that to us could well have been a warning symptom of a heart problem. And that might be excess shortness of breath or some chest tightness, but only a quarter of them had actually sought medical attention for that. So that was a concern, that they didn't seek medical attention. The other was that a half of them didn't feel confident that they would be able to diagnose a heart attack in themselves, and even less in other people. And 60% of them, so over a half of them, were not aware that you can actually have warning symptoms for a heart attack. So classically, people might think that they're doing well and then suddenly have a heart attack. But in over a half of people, there can be what we call these warning symptoms that first chap had, where when he was exerting himself, he may have got some chest tightness or excessive shortness of breath. And that's a good clue to recognize that. So that was a thing that we found. Also, we found that about 40% of them, so 2 in 5, when asked what would they do if they thought they were having a heart attack, would they get an ambulance or would they get someone to drive them to hospital? And 40% said they'd get someone to drive them to hospital. So that, again, is not good behavior, because if you get an ambulance, which can come quickly, then you're immediately a lot safer, because they have defibrillators and capability to do something. And the other thing we asked them is, what would you do if you had chest discomfort while you were playing soccer? And again, almost half of them said they would aim to keep on playing unless they really had to stop. So again, not an ideal approach. Having said that, they were very enthusiastic about learning more about what they could do to minimize their heart risk. And so based on that, we've then developed a study where we're actually going to look at what we can do to specifically educate people regarding warning symptoms, what to do if they might have suspected heart attacks. And that's something that Heart Research Australia is supporting. And we have focused on the football group, but I think it's also relevant to people doing all sorts of other sport in a social way, as well as perhaps competitively, and for other people doing exercise, because we do recognise, and I'm a very strong advocate of regular exercise as being one of those, and might come to essential 8 of ways to have preventive strategies. So exercise is very good for you, but also be aware that occasionally when your heart's put under stress, it might bring on the symptoms that are warning symptoms for a heart attack.
So, Jeff, you know, you and I have talked before about this. I mean, it's an outrageous suggestion, obviously, but if we were to put aspirin in the water like we do fluoride, I mean, that would prevent a hell of a lot of heart attacks in advance, really. People who I would suggest your figures, you know, if that's with soccer players, I would have thought those figures would be the same in the whole population. That most people either wouldn't recognise it or would just put it down to, you know, had a bad food last night or didn't agree with some food or something else. So if that's the case, you know, how do we? I mean, and people are probably going to continue to have that view. So how else can we somehow deliver drugs or whatever we need to stop them having the heart attack, even when they don't think they're going to have one?
Yeah, look, it's a very good point, Chris, and you and I have sort of, as you said, talked about this and worked together as well. And I value your opinion, and I learn, you know, far more from you know, people I see, patients I see, than often I can give. So what's very intriguing is that an epidemiologist from Monash, who actually I'm working with, called John McNeil, did a large study called the Esprit study, where it was essentially not all that different from what you're saying about putting aspirin in the water, in the sense that he gave aspirin to older people. This was, I think, people over 70, and so half got aspirin and half didn't, or got placebo. And he actually found that there was some reduction in heart attacks, but this benefit was overridden by the risks of aspirin, so that bleeding. So when you talk about someone who might have indigestion, maybe in fact he does have a stomach ulcer. So there was more bleeding in people taking aspirin without a good indication for it. So what John McNeil is actually working with us on a project called TARP, which is Triggered Acute Risk Prevention. And what we're proposing in this project is that we can identify periods of higher risk, and that higher risk might be associated with a higher risk of blood clotting and a greater benefit from a medication like aspirin. So rather than people without any other specific reason to have aspirin, rather than just generally taking it once a day, we're trying to again evaluate whether restricting it more to periods of high risk, such as when people have done heavy exertion, or when they're under particular emotional stress, or chest infection, or heavy meals, or pollution, these sorts of things that we're found to be triggers of heart attack, to try to restrict it a bit more for those periods of time.
So the idea is, if I understand that correctly, that in the event that they have a predefined thing which we know can cause a heart attack, like grief, or a fatty meal, or, you know, playing some proper football, maybe. Trouble with soccer players is the most energetic thing a lot of them do is combing their hair, which is probably not going to be a problem. But you know, if they're certainly undergoing some big exertion, and they can then take these pills even though they've got no symptoms, and that would then stop that heart attack occurring in the first place. Is that right?
That's right. What we've found in our studies, and other people have found similar, is that in between 1 in 2 or 1 in 4 patients who have a heart attack, if you look or speak to them closely, you can find a potential trigger, something that might have brought on the situation. So rather than heart disease being necessarily something that's just sort of a fairly steady thing, and then, or just gradually changing, and then people have a heart attack, we think that in many instances there can be something that triggers it, causes a change from being fairly steady to developing an acute symptom such as a heart attack. So again, it's something that we're evaluating. You know, when we talk about prevention, the typical thing is to talk about chronic risk factors. So a chronic risk factor is something that's there most of the time. For example, high cholesterol or high blood pressure. and treat that on a daily basis. But we're proposing that there's also what we call acute risk factors that can suddenly change the situation.
So one of your colleagues, Professor Gemma Figtree, she's been doing work on trying to identify patients who don't have any of the classic precursors for a heart attack, blood pressure or all the smoking and all those, haven't got any of those, and they still have a heart attack, which is much more likely to be fatal because they weren't expecting it and it'll be sudden. Mm-hmm. So are you suggesting that even people in that category would still cart around this little packet of pills and take that at the time of some extreme risk?
Look, what we're doing is we're saying, well, if we want to evaluate this, it's better to start with people who already have some higher risk. So again, we wouldn't want to do it for the whole population. So in a study that we're about to commence, we're going to look at people who already have 2 risk factors for heart disease or may have had heart disease already, because they're a higher risk population, and so that we think is more likely to get more bang for the buck with that than talking about it in all populations. But I think emotional stress is something that's a very important one. So we have done a study in bereavement, and bereavement is something that can be a very sort of powerful situation, the grief reaction. And in those people, especially if they may be already at some slightly higher risk for heart disease, we do know that their risk goes up. And so that might be a period that people would benefit. And so we did a study where we gave some of the bereaved individuals this approach, which we call low-dose beta blocker and aspirin, and did find some benefit in terms of reducing clotting risk, and also related to reductions in blood pressure and anxiety and depression. And so that was one study that was supported by Heart Research Australia, and another one more recently supported by Heart Research Australia. Like with Karan, it was for a PhD for Monica Ruckholt, and we looked there at the stress that relatives of people hospitalized are undergoing. So you may feel okay yourself, but if one of your family members is in hospital, we showed, not surprisingly, that there's a higher level of anxiety and depressive symptoms, reduced sleeping duration in those people who are the relatives. So that, again, we could say in some people that's a higher risk period.
Mm. Well, I must say that Heart Research Australia has been a champion of this kind of basic prevention technology for a long time. I mean, they were the ones who introduced the ATAMI system, where the ambulances carted around equipment that could communicate direct with the cardiologists at the hospital and cut down the time till you could actually get a stent put in to resolve a heart attack. And I'm a survivor of that. If I hadn't had that ATAMI system, I doubt I'd be sitting here talking to you today. So I think Heart Research Australia has had a real focus on supporting that research. And so this TARP, as you call it, where you can stop a heart attack before it happens, seems to me to be amazingly important. And thank you so much for the work you've been championing. I know that's been a cause that you've been keen on for many years. And I think we can all appreciate just how much thinking time you've put into that, and how much we can benefit from it. Felicity, it's been an extraordinary journey for Heart Research Australia, and Professor Tofler and Dr. Rao have certainly been part of that as we move forward.
They certainly have. So thank you very much. We do have some questions, if we're okay to answer those now. The first one we have is, could we speak about the effectiveness of CTCA?
I'm happy to start, Jeff, if you don't mind, I guess.
Yeah, sure.
CTCA, or CT coronary angiograms, have kind of been utilized quite a bit, I think, in practice, particularly over the past years or so. They provide quite a few additional bits of information. So I think the fundamental difference, I think, from CTCA, so it's quite similar to a formal angiogram. However, it's done non-invasively and it's done through a CT scanner, and it provides quite key information in terms of plaque, whether it's calcific or not, and a great tool to help in my practice, where I tend to use CT coronary angiography primarily, and where it serves a very good purpose. So it's an excellent tool with a high sensitivity. So its accuracy is particularly magnified when it's used to rule out coronary disease. So when there's a lot of calcium and when there's a lot of disease, it can often over or underestimate the true quantification, but it's an excellent tool when you're trying to look at low to intermediate risk patients, particularly when you're trying to rule out disease. It's got a very, very high accuracy, near 90 to 95%. There is obviously a few other things. I'm not sure if Professor Tofler wants to talk a little bit more, but that's where I tend to use it in my practice.
Yes, I'd agree with Karan. I think that it is emerging as a very helpful test, more non-invasive than coming into hospital for an angiogram. Having the quality of it, having it done in good centres is important. I think that if someone has symptoms like potential warning symptoms that I mentioned before, then something can be it ties in a little bit to one of the other questions, which is related to a calcium score. Where's a calcium score? That also is a test that can be very useful, because there's evidence that calcium is associated with plaque development. So if there are plaques in with calcium, calcium score from X-ray, then it's a very good pointer towards risk being low. So they're in a way complementary. I tend to look at the CT coronary angiogram as one that's more helpful when you're a bit more suspicious about something happening, or there's particular high risk that you want to look closely. Whereas the calcium score is again something that talk to your doctor about it for your own individual needs. But that is emerging as a very useful test, which adds to measuring your cholesterol or other risk factors.
Thank you, which nicely leads on to the next question, which you've mostly answered, which is how useful is the CT calcium score as a routine procedure?
Yeah, so as I said, I think that it's something that can be very helpful, and in people who you want to know what's your risk. Sometimes it's useful to know. The doctor wants to know, should you be on medication to lower the cholesterol level? Can you rely more on dietary approaches? And then if one does a calcium score and sees no calcium at all in the arteries, then that can be reassuring to press on with as it turns out, non-statin. Statins are the most common medication. But if you do see calcium in the arteries, then that would be more of a pointer to say you should be on a statin to lower, and possibly aspirin to lower your risk. Karan, I don't know if you want to add to that.
No, I was going to say the exact same thing. So that I use the CT calcium score predominantly, quite commonly, for that same reason, where if a patient is wondering, if they're on kind of equipoise, so they're kind of leaning either way, or need a little bit of extra evidence to support going on therapy, then the guidelines now truly support CT calcium score to help you make that decision.
Great. And then final question is, are nitric oxide production supplements like Neo40 effective in reducing coronary events? Who would like that one?
Karan, I don't know if you can answer that one. I think that Karan, can you?
I haven't had much experience with it, so to be honest with you, I would have to look up the literature myself. I'm not entirely familiar and don't know the data too well myself.
We'll get back to you on that one.
I think there's no doubt that nitric oxide is an important contributor to the health of the arteries, and so it's logical to ask, is there something that may help that it's beneficial? And as Karan and I are both implying, we don't know a lot about it, and it's important to look at what the evidence is out there, and always. And I think with Heart Research Australia are always very open to looking at new approaches, because even though a lot of what we currently do is helpful, as Chris said, there's still a lot of heart attacks and a lot that aren't explained by what we call traditional risk factors.
Great. Well, all that's left is for me to say a huge thank you to everybody for your time today, and also for all our attendees for joining us. We're so grateful to have you all here, and we hope you all enjoyed that chat. It's all been recorded, so I'll send a link out to that later on this week. So if you missed anything or you want to share with your friends and family, you can do so. Thank you so much for having us. And thanks, everybody.
Thank you. Thanks for having me.
Thanks, Chris.
Thank you very much, and thank you for being fascinating to listen to.